Hello and welcome to another episode of Jigawa in Focus, where we bring you the latest developments in Jigawa State. I am Sumaya Abubakar. Today we will be delving into the remarkable achievements of Governor Umar Namade's tenure in the Ministry of Health in Jigawa State. Commissioner for Health, Dr. Muhammad Abdullahi Kainua, shed light on the transformative journey of Jigawa State in the health sector. Take a look.
At the concept of this administration in the last 9 months, we have made very monumental achievements as far as the health sector is concerned. In the health sector, we have found out the debilitation of so many healthcare facilities, including general hospitals and primary health centers. We have found the lack of adequate human resource for health, in terms of doctors, nurses, pharmacists, technicians, and especially at the primary healthcare level. We have seen the incessant increase in the price of diesel, making it very difficult for the hospitals to run on 24-hour power supply. And these are some of the major issues and challenges that we have found. We have found that we need to complete some major projects that were being initiated by the last government. So in the last 7 to 8 months, we have made sure we solarized most of our general hospitals. We have solarized 24 hours, Kazauri General Hospital, Barbara General Hospital, Gumel General Hospital, Hadeja General Hospital, Kaping Hausa, Duse General Hospital. Arrangements are in the pipeline now to solarize Guaram and Bruno Kudu General Hospitals. On the issue of personnel, the government has approved that we employ 1,124 number health personnel to address the shortage of health personnel in the state. We have also been given approval by the government to employ another 1,000 J health personnel that have been taken on temporary basis that are posted to our health institutions. On issue of procurement, we have procured medical equipment worth more than 2 billion to complete the Kazauri and Hadeja Specialist Hospital that we inherited from the last government. We have also tried to repair and make to work new general hospitals in Gaza, in Buji local government area, in Garki local government area, in Guri local government area, and in Gwiwa local government area. Because of the passion of His Excellency to make sure that we have adequate health personnel and good structures at the local government and primary healthcare level, we have started building midwifery houses in 7 primary healthcare centers across the state. We have now given advert for the upgrade of 30 primary healthcare centers in the state. This upgrade will consist of building of midwifery houses, standard ones, with full furniture and DSTV connection, solar, water and power supply, wall fencing of the whole institution, so that 24-hour services could be rendered in all the 241 primary healthcare centers in 281 wards of the 27 local government area of the state. His Excellency in this government has also approved the institution of social insurance, that is equity funding in our insurance agency, so that at least 500 indigent individuals in all the 287 wards of the state will be covered by social insurance at the primary level. His Excellency has given the agency and the ministry 1 billion naira to conduct that, and there's additional 500 million naira that will be used for user fee if these people, any of them, would like to require any service at the secondary level. Mainly, these are some of the major issues that we have been able to accomplish in the last 7-8 months that we have been here. This is not to say that we have plans, and the plans are that we are going to repair and upgrade the College of Health Science in Jahu. We are going to provide another hostel for males and females. We are going to repair the wall pencil of the school. We are going to have additional staff housing. We are going to repair the present housing. We are going to landscape that area. And we are going to construct new general hospitals in Ringim and Kapinghausa. We are going to construct another at the permanent site of the College of Nursing and Midwifery in Hadejia. These are the major capital. And then, of course, we are going to complete the Kazaura Specialist Hospital and the Hadejia Specialist Hospital. Essentially, these are the issues that we have put in front of us that we really want to achieve this financial year. And that is not to say His Excellency has made us all commissioners sign a performance bond with him. He is following us every quarter to make sure we are going to achieve all the objectives that we set to achieve. Failure to achieve these objectives consecutively in the next 2 quarters will have any commissioner will have no option but to resign his appointment. So consequent of that, we are reorganizing the Ministry of Health, the JICHMA, that is the Jigawa State Contributory Management Agency, the Primary Healthcare Development Agency, in line with global best practices to make sure that we have a team that can be able to implement these laudable objectives of the government of His Excellency Malam Umar Namadi FCA. In the same line, we are reviewing the laws that we have, the law establishing the Jigawa State Contributory Management Agency to include equity funding and social insurance and the money that will be accrued in that aspect. We are also reviewing the law of the Jigawa State Primary Healthcare Development Agency to make sure that government makes sure that all the staffs in the local government will be under the control of the Primary Healthcare Development Agency for their remuneration, for their posting, so that those health facilities and local government that do not have adequate staff, the Primary Healthcare Development Agency will be free to post those staffs to areas of need, so that we will not be able to concentrate more staffs in one particular local government area when other local government areas are serving as medically underserved areas. We have also instituted and passed a bill, which is now will be sent to the House of Assembly, on health security. We have all realized what happened with the outbreak of the pandemic, the COVID-19 pandemic in the year 2019, 2020, and 2021. What happened to closure of markets, mosques, and what have you. We wanted to institute a health security bill that will give government power, so that when any time those particular kinds of incidents happen, government will have the legal backing to do what is necessary to protect lives and livelihoods of our people in our own community. We already have this pre-MNCH program since the last government. We give the hospitals and primary health centers about 75 million naira monthly for this issue. When we came in, we found out there were a lot of issues with the provision of free medical services. We instituted a committee on free MNCH and DRF, and the committee has brought out its report, amongst which we were not buying drugs from JFARMA, the company that was established by Jigawa State to provide drugs and consumables for all our primary and secondary healthcare centers. Now, every hospital, every primary healthcare center must buy from JFARMA. And number two, we have tried to see that only women and children, only pregnant women and children under 5 are given those medications, wherein we find some abuses, wherein the money was being misplaced in buildings, in maintenance, which is out of the scope of the particular hospitals. So we made sure that all the money that is given to the hospital to provide those services are now providing those particular services to our people. So the things have gotten better. Now we see that we have less maternal mortality, less death of women in pregnancy in our health institution. We have more women going for antenatal clinic attendance. We have more deliveries that are being taken in primary and secondary healthcare centers. Issues of nutrition and health education are continually going on. And please not forget that in this year and last year, we had an outbreak of Lassa and diphtheria and meningitis, which we have all taken control of by vaccine that were given by the government of the Federal Republic of Nigeria. We have done the campaigns and the spread was curtailed throughout the state in addition to these other things. So the issue is that now we have expanded the number of hospitals and the number of local governments that we are going to give free drugs. Hitherto, it was only given in general hospitals and some 12 primary healthcare centers. When we came in, we found out that there are some local government areas that are not being served. So these new local governments we're in, we are now completing their general hospitals, like the one I said in Gansa, in Guri, in Gariki, in Gwiwa. They are coming up with pre-MNCH. And when we repair all these particular health facilities that we made advert for, we'll make sure that we see that there is an expansion in the reach of the pre-MNCH care to include more facilities than we're trying to do right away. The JICHMA that I'm telling you is the Jigawa State Contributory Health Management Agency. And I think I mentioned it about 3 to 5 times in the previous speech that I made in this interview. JICHMA is the same as NHIA that you have, or is a complement of the NHIA that you have in the federal government. It is charged with giving insurance to those civil servants that enroll in it and their dependents. In addition to that, we are going to add another job to JICHMA. That is the social insurance aspect, which I said the governor has approved us to identify 500 vulnerable groups, vulnerable people in every of our 287 wards. This money is going through JICHMA to the primary health care centers wherein these individuals are going to be enrolled. JICHMA will be the one paying the capitation to these particular health facilities to be able to give this social insurance cover to these 500 people. That is why His Excellency saw that pertinent to improve the healthcare facilities. That is why we are advertising for the well pension, for midwife houses, for solarization of primary healthcare centers. That is why His Excellency has given us the approval to employ more people at the primary level, because these facilities must work 24/7. So if there are no workers, if there is no power, if there is no security, there is nowhere these 500 people are going to get this particular service. So all the things that we are doing at the primary level are in line to see that these 500 people from every ward have access to a hospital wherein they could address their own primary healthcare service 24 hours and 7 days in a week. That is why we are doing all this. So you look at the focus is to provide social insurance. The social insurance is to make sure that people reduce the out-of-pocket expense that they spend on health. If this money is there, His Excellency thinks we are doing positive things to get people out of poverty. So the whole essence is to get the people of Jigawa State out of poverty. And before the end of this term, His Excellency made it his business to see that about 30% of the population of Jigawa State will be enrolled in social insurance. That means all the 287 PHC facilities must be repaired to standard. It means all the facilities in the PHCs must have adequate, commensurate human resource to be able to address that. It means there must be adequate drugs that are coming in. And we have started that by giving 30 million naira, 1 million naira to each of the primary health care centers to procure adequate drugs from JIFAMA to make sure that they have drugs existing for those already enrolled by JICHMA in the insurance cover that they're giving civil servants and their dependents, and in anticipation of the social insurance that the government of Jigawa State wants to institute in the next 1 to 2 months, inshallah. Emergency Transport Service, ETS, these are people that we engage in all communities in Jigawa State. We have a budgetary provision that has been approved by His Excellency. We are giving them a token of 5,000 naira per trip to carry any pregnant woman in any hour to the nearest primary or secondary healthcare facility. They have a register that they register, and we pay them based on that. Because one of the most important reasons for morbidity and mortality of women of childbearing age or during pregnancy are the three delays. The delay in taking decision in the family to take them to seek care in the hospital. Number two is the delay in reaching the healthcare facility. Number three is the delay in the healthcare facility. In addressing quality issues, we have Jigawa and other partners are addressing the quality issues in our own general hospital and primary health care center. Immediately a woman reaches there, she does not go through the normal outpatient department, she goes straight to the maternity. The card and the everything is given there. There is a side lab, that will be able to take her blood and what have you, and do what are the needfuls. And then there will be a doctor that will look at her and a midwife that will take care of her and a bed that will be given her to make sure that that woman delivers safely. We have addressed the delay in the health facility. Addressing the delay on transportation is sectoral. We do not have ambulance in all our communities. That would be almost impossible for any government to attain. So what we did was to employ emergency transport services, whereby we engage people with transport in all the settlements through our own Jakarta Lapia in that village or in that community, so that we have a dedicated driver who is resident in that community. Anytime that there is a request for transportation of a pregnant woman in that hard-to-reach area, that person will be able to transport that woman directly to the primary or secondary healthcare service, and he's going to be paid per trip of what it takes. That program is there, it is running, it is more emboldened than it used to be.
Like most people in Africa, maternal mortality remained a big challenge in most of the system they were working with in the last more than 20 years or so. So we look within us to see what were the problems responsible for high maternal mortality. That is, women who are pregnant and they are not able to carry pregnancy, or they die as a result of pregnancy, after 6 weeks after delivery and so on. So some of the problems we realized were there were some delays in accessing care. The first delay is around taking decision at household level that this pregnancy is complicated and needs to go to a health facility. The second delay is around, if we have made up our mind that we need to go to health facility, how do we get to the health facility? Imagine a scenario whereby a woman is living in a rural area where there are no tarred roads, there are no cars, there are no facility where she lives. It has rained, the roads are bad, and just there is no vehicle or road, and there's a bleeding, and you need care within the next half an hour or 30 minutes or 1 hour. So that is a second delay. That is the means to which you go to the health facility and get services. And then the third delay is when you go to the health facility, the time that is spent before care is provided. So we fragment these systems and understand that the most critical area, which is not really is not attracting substantial resource, is the area of transportation of women in need of services during maternal emergencies. And that is the reason why we came up with a program of saying, what can we do to improve the transportation of these urgently needing women who are in need of services from where they live 24 hours round the clock and so on. So we look at the framework and see ambulances are supposed to provide this kind of services, but they are not enough. In Jigawa, we have 12,681 communities, and there's no way we can provide 10,000 ambulances to everyone. So that actually goes out. The other issue, we say, okay, can we leverage on road transport worker union to see whether they can provide this kind of support? We engage over 1,000 of them, train them, and provide them with incentive. Again, because there is no accountability, the driver has loaded that wants to go to Potterscombe, and you call him that you should drop those passengers and carry a pregnant. That is not going to be sustainable. So it did not really go very well. We had to drop that idea because they were not accountable. They are not under our care. They are not under our pay. It's a volunteerism, and so that did not work for us. The next thing we say, okay, now what can we do again? We advise government to sort of procure committed vehicle for this scheme. And government responded to this need about 15 years ago, and then we bought about 120 golf vehicles and distributed them to places where this event can happen. Again, there were issues because this vehicle could not be maintained, because community people do not know. When they open the bonnet, they don't know where water goes in and where fuel goes in. Somebody that has never had a vehicle, we are giving him a car to maintain. That's not going to work. Within 3 years, all this vehicle really broke down. And we had to come back to the drawing table and say, let's be innovative. And that's what gave us what we call Community Emergency Transport Scheme, which we gave birth here in Jigawa State. Under this scheme, We appraise every car owner, private car owners. It can be you, me, and any other person, but you must live close to where this kind of services are needed. And we identify the communities that we are cleared or we are labeled as hard-to-reach communities. There are about 750 of them across all the LGAs. If you are living far away from a health facility, that is a criteria. If you do not have a facility in your village, that's a criteria. If you don't have third road, that's also a criteria. So people who have this kind of combination, there are about 750 communities within this system that we're working. And in each of these, we identify drivers that live close to these communities. So somebody who has retired and want to participate, we engage all of them. Right now, we have engaged over 350 drivers. We give them training and orientation. We give them issue-related confidentiality and privacy of women and how to transport women who are in sick condition and so on. And each of them that transport women, that person is credited with an amount of money equal to 5,500 per trip. So we've been doing this for the last 3 years or 4, and it has been showing results. Only this year, between January and February, we transported 520 women, and none of them lost their life as a result of transportation-related emergency. In fact, in the last 3 years, we only have documented 4 mortality related to delay in transportation of women from where they are to health facility. And within these 3 years, we have transported thousands of women with this kind of condition. So this is a scheme that is tested and trusted.
This work is progressing smoothly. There has been improvement in health sector since this government come into power. Pregnant women suffered before reaching the hospital. And many men didn't have money when their wives were about to deliver. They did not know how to transport them to the hospital. However, with the intervention of this government, even at the midnight, we take them to the hospital for free and all medical expenses are covered. We used to take pregnant women to the hospital around 30 times a month. Since this government came into power, the payment we receive from the government has been low, but the Modi administration has increased our allowance. I went into labor around 11 p.m. and the driver arrived to take us to the hospital. I delivered successfully and they provided us with medicines. The driver took us back home, all free of charge.
For the health sector, where almost 20.3 billion is earmarked, the major proposed investment will include primary health care project and program, including supplementary immunization activities and upgrading of some primary health care centers, 5.9 billion. Improvement of general hospital, 5.5 billion. This will include, among others, the improvement and upgrading of certain number of secondary facilities to full-fledged general hospital, construction of 3 new general hospitals at Ringin, Taura, and Kappenhausa, provision of staff quarters, equipment for new orthopedic hospital Gumel, and the establishment of new dialysis and oncology centers in 3 general hospitals. Contributor health insurance program and community health insurance counterpart funding, 3.7 billion. This will include funding from the Basic Healthcare Provision Fund and establishment of state equity fund with a seed funding contribution of 1 billion naira by the state government. Prematernal and child health care program in primary and secondary health facilities, the coverage of which will be extended to all the 27 local government areas in the state, 1.5 billion. Development and expansion of health training institutions, including the establishment of School of Midwifery in Hadeja, 1.4 billion. Health Emergency Preparedness Response Program, 605 million. Development of ward-level facilities for basic health care provision, 497 million. Food and nutrition program activities, 324 million. Other proposed investment in the realm of social development include women development, social welfare, and social protection activities, including the implementation of Nigeria for Women project to be supported by the World Bank, This will also include the establishment of 4 additional sexual assault referral centers at Hadeja, Gumel, Kazaure, and Ringim General Hospitals.
In conclusion, the strides made under Governor Umar Namadi's leadership in the Ministry for Health of Jigawa State are nothing short of extraordinary. Through innovative initiatives, strategic partnerships, and unwavering dedication, significant progress has been achieved in improving healthcare delivery and outcomes for the people of Jigawa State. And with that, we wrap up this episode of Jigawa in Focus. I am Sumaya Abubakar. Thank you for watching.
abinci zai wadata a koyaushe